Welcome to the Radiology Scholars Certificate Program. My name is Benjamin Highland. I'm a fourth-year medical student at Wake Forest School of Medicine, and I'm going to be talking to you guys today about radiology pathology correlation, focusing specifically on fibrocystic change and fibroepithelial lesions of the breast. We're going to frame our discussion around two patient case presentations. So patient number one is a 53-year-old white woman. She has had a right breast mass for 1 year, and she has a history of anxiety, depression. Her labs are unremarkable, and she has ended up getting an imaging study done, which is going to be a mammogram of her right breast. Compare this to patient number two, who is a 27-year-old white woman. Her chief complaint is a palpable, mobile, non-tender lump in her left breast. She also has a history of anxiety and depression, also unremarkable labs, and she's going to get an ultrasound of her left breast mass. So let's go straight to the imaging. So patient number one, we have her mammogram right here. This is our 53-year-old woman. And just as a reminder, if your patient is over the age of 30 and they present with some sort of a breast mass, we will start with mammography, and we may or may not get an ultrasound. But looking at her mammogram here, we can see that there's kind of heterogeneously dense breast parenchyma. There's a large encapsulated, circumscribed, mixed, mainly isodense lesion that is seen in the right lower central region of her breast. Now compare this to patient two. She is our 27-year-old woman who, as we mentioned before, is under 30. So she's going to get a breast ultrasound instead of a mammogram. Her ultrasound shows a left breast with a well-defined hypoechoic ovoid lesion at the 2 o'clock position in the upper outer quadrant of her breast. The lesion is wider than it is tall, and it has well-defined margins. There's no internal vascularity or microcalcifications, and there's no evidence of any architectural distortion or skin changes. So that brings us to our learning point. What are the features that you may see on a mammogram that would kind of tilt you in one direction to say this is more likely benign or more likely malignant? Well, one thing would be the shape. If you have a round or oval mass, that's more likely to be benign. If the shape is irregular, that would be a feature that's more concerning for malignancy. Another category is contour. So if the mass is well-defined, circumscribed, maybe it has a radiolucent ring surrounding it, something called the halo sign, that is something that is more likely to be benign compared to a non-circumscribed mass with indistinct or microlobular borders or spiculated margins, which you can also call a stela mass. That would be more likely to be malignant. In terms of density, a low or mixed density lesion, could be an oil cyst, or maybe there's a fat fluid level in there, would be more likely to be benign, whereas higher density would be more likely to be a malignant lesion. And finally, calcifications. If there's macrocalcifications, it could be, for example, a calcified cyst. If there's coarse popcorn-like lesions, like calcifications in the lesion, or if there's kind of diffuse microcalcifications, which would maybe be indicative of fibrocystic change of the breast, then that is more likely to be benign. Whereas if there's clustered microcalcifications or microcalcifications in kind of a linear line, that is a feature that would be more concerning for malignancy. So both of our women have breast masses, and what could be causing this? Well, the differential is, broadly speaking, a breast abscess, a breast cyst, fibrocystic changes, fat necrosis, some sort of fibroepithelial lesion, so for example, fibroadenoma or a Phyllodes tumor, or something worse, such as malignancy. So there could be LCIS, DCIS, or some sort of invasive carcinoma. So in these cases, patient number one, just based on the imaging, we're probably going to assume that is a fibroadenoma. Patient number two, based on her age, should be more likely to get a biopsy. So now we're going to look at some histology of different lesions that could show up in the breast. And we're going to concentrate specifically on benign conditions, looking specifically at fibrocystic change, the spectrum of that, as well as fibroepithelial lesions. So let's talk about fibrocystic change in the breast a little bit. So this is going to be a spectrum, and there are several things that exist along that spectrum. First, you can have fibrosis, which we can see demonstrated right here. You can see that the stroma here is just more fibrotic than perhaps it is over here. We could also have formulation of microcysts, hence fibrocystic change. So you can see these cysts forming right here in with a kind of a fibrotic background as well. But they're just these round cysts with what appear to be kind of cuboidal cells, just a single layer of those. We also may find sclerosing adenosis, which is a proliferation of the terminal ductal unit. And here we see this proliferation, which may be a little bit worrying for something more like invasive carcinoma at first glance, but it will stain positive for P63, which is a nuclear stain, for SMA, which is a cytoplasmic stain, as well as Calpone and SMM, which are also both cytoplasmic stains. There also will be no desmoplastic change, which you would see in a more invasive carcinoma, and there'll still be an intact layer of myoepithelial cells, which you would not see in invasive carcinoma. We also have apocrine metaplasia demonstrated here, and you can just see that the cells lining this gland are becoming a little bit more eosinophilic, as well as maybe slightly papillary as well. So this can kind of describe apocrine metaplasia. Finally, there may just be some usual ductal hyperplasia. So you can just see that this cell layer is getting a little bit thicker, but there is still the kind of outlining layer of myoepithelial cells. And they're still kind of jumbled as well, so we're not too worried about DCIS or something like that. And we can get a CK56 stain to kind of verify that if we want to. So what about the fibroepithelial lesions? Well, we have two main types we're going to talk about here. So there's the fibroadenoma, which is much more common, and the phyllodes tumor. So talking a little bit about fibroadenoma first, it's going to be a benign biphasic fibroepithelial tumor composed of glandular and stromal elements. Histologically speaking, you're going to have a more uniform cellularity, and there's going to be this proliferation of the stroma that you can kind of see demonstrated here that is going to form these slit-like ducts because of the proliferation of the stroma, which is compressing them. So this is a fibroadenoma here. We could describe this as a uniformly low stromal cellularity with no stromal cellular atypia. Compare that to a phyllodes tumor, which we have demonstrated over here. This is again a biphasic fibroepithelial tumor composed of glandular or stromal elements, but this time it may be malignant. It could be benign, but it may also be malignant. Histologically speaking, this is going to have a much more abundantly cellular stroma, and we're going to be forming these leaf-like projections into a cystic space. And we could describe this as a benign phyllodes tumor with characteristic leaf-like epithelial pattern. So let's sum everything up. We had our two patients. The first patient was a 53-year-old woman with I believe, a right breast mass, whereas our second patient was a 27-year-old woman with, I believe, a left breast mass. In the older 53-year-old woman, we got a mammogram because she is above 30, and in our younger 27-year-old patient, we got an ultrasound because she is below 30. Now, it's important to note that an ultrasound and a mammogram do not accurately differentiate a phyllodes tumor from a fibroadenoma. To do that, you need to have some histology looked at by a pathologist. And even then, it can be slightly difficult to tell the difference, but it can become very important as a fibroadenoma really has no chance to become malignant, whereas a phyllodes tumor could undergo a malignant transformation and cause some more serious issues. So a fibroadenoma, most common breast tumor in adolescent and young women. Treatment for that is going to usually be conservative management, so we're just going to do close clinical follow-up as we would have done with this patient. She did not get a biopsy. And if there is a especially symptomatic fibroadenoma, it's possible that we could do a local surgical excision. But generally speaking, the prognosis is good because there's no chance for malignant progression. A phyllodes tumor, on the other hand, most common in kind of older women, 40 to 50. And the treatment here is always going to be local excision with clear margins due to the increased chance of malignancy. The prognosis is going to correlate with the histological grade, benign, borderline, or malignant. So now we've come to the end of the presentation. We've walked through our two different case presentations. Our younger patient who got the ultrasound because she was below 30, our older patient who got a mammogram because she was above 30. We talked about some of the mammogram features that could be concerning for malignancy versus a benign lesion. And we talked about some of the histology of fibrocystic change of the breast, as well as fibroepithelial lesions such as fibroadenoma and a Phyllodes tumor, and why it's very important to distinguish those. Thank you guys so much for listening, and have a great day.